this is my own practice. We're going on second year now. I think what I'm doing is just building up my practice because we're starting from scratch. We're not attached to any health funds. So I'm just going to explore building up clients and also looking at increasing my skills in different aspects as well so that I can do more work. The things I'd like to focus on is actually braces, orthodontics, which is how I knew you in the first place because I did the study through POS group, and then I saw your course, and that's when I did it. I think it's probably almost 2 years now. I think it's almost 2 years now.
I was there.
2006.
I don't remember. About 2 years.
Yeah, I think close to 2 years now, and I think that was really good because I think that course really add a lot because I think I haven't done anything perio-wise since high school, and all you were taught really is just cleaning. Yeah, so perio surgery was something that we never really taught very well, and I think that was for the first time I actually appreciate the soft tissues, because before that, when you're looking at the problem, it's like, oh, this is too much, we'll just refer. And before that, I didn't even know that, okay, what can a periodontist do? So it's really hard to refer to them as well. So that's why I thought that was really good, because it adds a whole an aspect. And once I've done that course, I realized that actually a lot of people were doing these things, like general dentists doing like crown lengthening or soft tissue grafting. And I thought, yeah, and once I've understood that, it's not just the soft tissue management, it's like other things that I'm doing, like extractions and things like that. It's a lot better as well, because you have an appreciation of like what's happening. So I still want to continue doing that because I think it's going to add to the what I'm doing. With crowns or onlays and things like that, I actually do a lot of what Pascal is mentioning. So a lot of time I elevate a lot of the margins, but there was times when I look at it and said, yeah, having to think about it now, I said maybe it would have been better with crown lengthening.
It's simple. It's simpler.
Yeah, it's not necessarily. It's just that sometimes I can get away with most of the things, but there was time when I found it really hard to put matrix around the tooth and whatnot, because it was just, once I've removed the thing, it's we're right onto the bone level, so you can't put matrix between the bone and the tooth. So sometimes I find that was would be helpful to do that. And actually recently I've done one functional crown lengthening. I haven't shown you this yet, but I think I posted on the Facebook, the pre-op, and I asked you about what to do. So I've actually done it, and I'm still reviewing it. I'm not sure, do you know how I can actually share my screens?
Yes, you can. Go to the bottom of the screen, and it says share screen, and then you pick the window that is. I'm sorry, I did not have lunch. Do you mind if I munch during our discussion?
Yeah.
Do you mind?
Pardon?
Do you mind if I munch on something while we talk? Because I didn't have my lunch. Sorry.
Yeah. Yeah. Right. Where's the share screen? At the bottom. Yes, I can see that.
It's a green button.
Okay. Can you see it now?
Not yet.
No. Oh, okay.
Not yet. Now I can see. Now I can see your screen.
Okay, good. So that's her that I did the crown lengthening on. So that was her.
Okay.
Let me just get the X-ray first. That's probably the best one to explain. That's the issues. Is that she had root canal done, and we're looking at doing an onlay crowns on that tooth, and the margins on the distal was quite deep.
Can I stop you for a second?
Yeah.
You tell me how you can do this without crown lengthening, with margin elevation. How are you going to isolate on the bone level and build up with composite? How is that going to work? I'm not doubting it's possible, but how to foresee it? I don't think it's practical.
Yeah. I will put rubber dams on. Usually, I'll probably split the dam between the premolars and the molars, and then it's just a matter of just getting matrix on. And once you've got the matrix on, I need to make sure that I can wedge it hard so that there's no fluid seeping through the matrix. And it depends. Most of the time, I can do it. There was time when it was really difficult. I find a lot of the time, if the margin is already deep like that, has been there for a while, there's already a little bit of bone recession. So there's a little bit of room to do that. And as long as I can get the matrix in and wedge it, and make sure that everything's clean, I sandblast the tooth, make sure everything is all clean before I seal it. So I follow the protocol. It can be done a lot of the time, but sometimes it was a little bit more challenging than the other. I had an issue with one of the patients the other day because it was the last tooth in the mouth, and the clamp of the rubber dam is on the tooth, so it's hard for me to get the matrix around it. Whereas like the tooth that's a little bit further towards the front, it's not as bad. But I thought, you know what, with this one, let's do it. I thought I said, let's do crown lengthening.
Okay.
Yeah, this is like, why not? Try something different. And it was quite interesting. I learned something from it as well when I was doing it. And anyway, with these ones, like the one behind it, you can see that you had the deep fillings on the distal of the 3/6 as well, and you can see there's some calculus build up there. So I thought, this is the perio issues. So I thought, if you're going to crown lengthening around this area, you probably can do the one behind as well. Because in the future, if I need to do a crown onlays on that tooth, then it's there. And if it's not, then the patient can clean better as well.
Makes sense.
Yeah. Now, when you mentioned about the doing the crown lengthening, I went back and I looked at the design. Actually, I probably changed the design a little bit.
Okay.
Because I was thinking that the way I'm doing you can say the occlusal coverage is I usually just do onlays. Let me show you some pictures of the ones I did. Okay. So you're seeing like some of these two, when I'm actually elevating the margin.
Yeah.
I've got the matrix to cover the whole surface. Even a lot of them are actually underneath the gum.
Mm-hmm.
And then I blasted, I bonded, and raised the margin, so it looks somewhat like that when I bond the onlays on.
Nice.
So as long as it's clean, a lot of time I can manage it, and the taking the impression is not too difficult because the margin are usually well up. Even Pascal would say that this is probably a bit too much. I'm just trying to see how my work goes and like review if there's any issues with the patient. I've been doing this for about 2-3 years now and haven't really had any issues with the patient. And coming back, I look at it, it's still there. But again, like I'm still young, so I've only been doing this a few years. So I'm just, I want to see how long-term things are doing.
Okay, good. Good. You're doing a good job. So you didn't do crown lengthening here. Here you did a margin elevation, basically. Mm-hmm. So there was no crown lengthening done, only a margin elevation?
No, but that was a different case. I'll tell you a different cases. Now, this case, I did the crown lengthening. Let me find the photo.
Just a second, Dr. Super. Give me a second.
Yep.
Yes, show me.
The reason why I told you about that was just to give you the idea that most of the time I do bonded porcelain restorations. So that means
which is good, because you don't need the ferrule effect.
Yeah, that's right.
You don't need the ferrule effect, so you're saving a couple millimeters.
Yeah. Now with this case, the premolars, you've got the deep margin on the distal, but not on the mesial. That's why when I designed the crown lengthening, I didn't extend it to I didn't extend the bone reductions onto the mesial. So when you think about it, it's almost I'm designing the crown lengthening for the 3/6. So you get the bone reductions and the gum reductions on the mesial and the distal of 3/6, which will allow me to do the onlay on the 3/5, and also get the benefit of the
perfect.
Yeah, the exposed margin on the distal of 3/6 as well. So even though
very good.
Yeah, so even though we're aiming to do it for the purpose of putting the onlay on 3/5, it looks as if we're actually doing a crown lengthening around 3/6.
Okay.
Yeah, and I'll show you the photos. So that's the photos as I was doing it. I found what's the challenge with it. Okay, because you know how like when you outline your step, when you do a crown lengthening, you're doing a crown prep first and got the provisionals in there. So when you're doing a crown prep, it's a lot easier to access interproximally, because when you're doing a crown prep interproximal, that means there's a big gap between two teeth, so that you can
contact. There's no contact.
Yeah, that's correct. So that you can go in there and remove bone interproximally really easily. Now I didn't do that because this is going to be an onlay, it won't be a crown prep. So I have to work from the buccal and the lingual aspect, and that's what I find is very challenging. So having a look at it to see it visually and get access with the burr as well. So that's what I learned.
Now let me give you some advice here. You see, although you're not planning reduction on 3/5 mesial, you can still reflect the flap.
No, I did.
You did. So you reflected between the two premolars?
Yeah, I went from the distal of 3/4 all the way to 3/7.
Perfect. You did well. Because that's only for access.
Yeah, so I just didn't remove any gum around there. I just run it through the... let me see if I've got other photos. So that was me trying to take the photos of like the tissue reductions between there. On the lingual, it's actually made that was really difficult for me to get the reflections on the lingual, and I was a little bit concerned about, you know how they said that there's lingual nerve down there, and you want to avoid reflecting the flap very far down on the lingual.
No, hold on. Let me tighten this point.
Yeah.
There's no problem reflecting a full thickness flap.
Yeah. Okay. Yeah.
Don't be concerned about that. That's actually okay as long as you go full thickness, because the lingual is going to go. I'm going to kind of draw on your picture.
Yeah.
Annotate here. Let me draw on your picture. Okay. So if you go full thickness.
Yeah.
Okay, like that. And even, I'm not sure if there's a third molar, but you can even go on top of the ridge somewhere here. Reflect full thickness. There's not going to be a problem because the actual nerve
in the soft tissue
is going to be in the soft tissue somewhere here. And then going to the tongue in the tissue.
Yeah.
So I don't see that there's a problem reflecting a full thickness flap. Quite the opposite. It'll give you more visibility, and you need that because you don't have the luxury of no contact point like a full coverage crown. So you have to work from here and from there. Then that's where hand instruments are very important.
Yep.
You with me?
Yep. Let me go through some more pictures with you. So that's.
Let me clear the drawings here.
Yeah.
Okay.
So that's
okay,
the.
So you did well. Oh no, you have great access here.
Yeah.
That's good. I mean, you lose the papilla pretty much. You lose the papilla.
Yeah. I find it like because there was not a lot of access interproximally between the 5s and the 6. It's quite hard removing a lot of tissues in between. That's what I find difficult.
Use a curette. You can use a curette. Just 13, 14, younger goods. Just a curette. Go in there with a curette. That's it.
Yeah. And I find that process of actually reflecting and cleaning this up took quite a long time before I even get to the bone removal. And the photo is not very good, but I'm going to see if it's visible at all. But you can see that's a filling.
Yeah.
Yeah. That's a filling right there. And the good thing is that when I'm actually reflecting on the lingual, I can see there's a deficiency there. I can see where the deficiency was. The issue with this one, when I did crown lengthening, I'm not sure if I've actually removed enough bone. I have a feeling I didn't remove enough bone.
You probably left a little ledge.
Yeah.
You probably left a little ledge, which is a common mistake, and it happens to me sometimes. All you need to do is take the ocean beam. Do you remember what the ocean beam looks like?
Yep.
Or a straight chisel, and just towards the end, just chisel close to the tooth. Forget about the burr, because the burr, you don't want to touch the tooth, right?
Yeah.
So just use a chisel.
Yeah.
Because it could be soft tissue granulation, but it looks like a little bit of like a shell of bone.
Yeah.
So just use hand instruments. That's that's the key here.
Yep.
But no big deal. You see, that's the nice thing. Super.
Yeah.
This is the nice thing. You are doing an onlay, and that's why you learned this for a few years now. You don't have to be like a dummy. Okay, Ziv said I need 4 millimeters. I'm going to reduce 4. You don't need retention and ferrule.
Yeah.
It's a bonded restoration. All you're trying to do is get some of the biologic width. You need only actually 2 millimeters.
Yeah.
Makes sense. And I think you know what I'm saying, because obviously you did that. So you can be very conservative. And I like this approach. I like this approach a lot because you're being conservative with your surgery. You're being conservative with your restorative.
Yeah.
So I give you an A+ for one of my oldest students. Okay.
So that's on the lingual. The flash is not very good, but that's where
I can see that. So you got 2 millimeters apical to that?
I don't think I did.
Okay, so not enough.
Because when I pick up the camera, the blood is probably gone everywhere by then.
Okay, listen, but at least you understand the principle, because that's actually an area that has access.
Yeah.
It has access. You can actually go all around it, blend it to the molar, blend it, gradually blend it to the mesial without reducing bone on the mesial, but just blending it in. So for next time. And you'll see it when you restore the tooth. You'll see what happened, right?
Yes.
Very good. Nice.
The other
was there a little perforation there?
I'm not sure.
Looks like some type of tissue damage.
Probably. It's probably when I was reflecting and retracting. There's probably pressed a lot on the tissues from the other side.
You see that? You see the circle?
Yep.
Dr. Super, don't think that I don't see things. I'm looking at every detail here.
No, that's good. I'll tell you what I think as I go back, I didn't remove as much bone as well. And the other thing, this one, I found there was a problem is that because I didn't have the exposed contact, I think when I try to tie the suture, it's still it's above the contact as well. It doesn't go through down the contact. So what, you know what I mean?
So what does it mean? What type of suture is that?
No, just
I see.
Just to interrupt. I'm saying that between the contact, part of it is under and part of it is on top.
Oh, I see. Well, you have to when you pass the needle, you have to pass underneath. You have to No, you have to pass underneath. You have to use like a larger needle.
Yeah.
About kind of a 7/8 curve that goes right underneath and come back the same way. Okay, well, and that's why it's hiked up. But it should recede down. It should recede back. Yeah.
I've only got the review post-op for. You can see how that sits. The one side sits on top. The otherwise it's it fits through the bottom.
I see. Yeah. To be honest, I think this restoration needs to be redone anyhow.
Yeah.
It looks like the margins here are right here.
Yeah.
I think it needs to be redone. It's like over contour just to close a space or something.
Yeah.
That's the next project. And you know what? If you need to do it, then you redo it, and you don't have to charge the patient again.
Yeah. I'll go to the post-op photo. That was week 1, so you can see that's.
Yes. Okay.
And but the good thing is that actually patients were quite surprised. She didn't have any pain. There's no pain. Yeah. She had no issues with it whatsoever. So that was the first week. And I just told her not to clean around that area, as in like interproximally just yet. But after that's a second week. After the second week.
You see some of the sloughing there, the gingival margin?
Yep.
You see this a little bit in here?
Yep.
That's because of what happened there. If what I'm seeing is correct. But you also see that the tissue shrunk.
Mm-hmm.
It's not hiked up here. It's shrunk down. Okay, so no big deal. Yeah, and that's only work with a rubber tip.
Yeah.
You need to do a little bit of work with a rubber tip to make sure this tissue tightens up a little bit.
Mm-hmm. Yeah.
And then you could tell this patient that the filling needs to be redone also because it's retentive to plaque.
Yeah.
And then formation of calculus causing bone loss. Just to tell this man or woman that there's a benefit, there's a health benefit to replacing it. It's not aesthetics.
Yes. Cool. So that was her, but that was a few weeks ago. And the next time I'm reviewing her is the 6-week mark. So I checked the first week, second week, and then the next time will be the 6-week marks. Okay. So I'll be excited because after the second week, I get her to use the interdental brush like TP.
Okay.
Yeah. So I think the tissue will probably shrinks a lot. But I have yet to see her because that's probably coming up in the next few weeks.
Okay.
Yeah.
So good. Saltwater rinses, rubber tipping, TP brushes, interproximal brushes. It should look by 6 weeks. It should look pretty healthy.
Yeah.
Good.
Yeah. So there you go. That's my latest one.
Okay. Good progress.
Yeah.
It's a process. It doesn't happen overnight. It takes a few months.
Yeah.
What else you got?
This is a friend of mine. He's pretty keen on the fixing these recession, and I think it's a good candidate. I think it's just going to be a little bit more challenging for me because I've never done posterior grafting before. Like CT grafting.
Okay. Well, you've done it in the front. You've done it in the front.
Yes. I've done it to the front once. And this is still the upper left and the upper right side. And I think this is purely, I think it's the brushing, because his cleaning is not bad. And they just isolate. It looks like a very good candidate for the CT graph, just because of the papilla is pretty high, and the damage is really limited to the mid roots.
Right,
of these things.
But it's a little bit inflamed. The papilla is also inflamed, so that gives you sometimes a false reading about the height.
You mean here?
Yes. You see this is the height of the papilla.
Yep.
So technically, if this is the recession, you would say 1, 2, 3. You can get this covered probably.
Yeah.
Okay. Don't worry about this. The canine is actually short. He has short teeth. He has a peg lateral. This is a peg lateral.
Yeah.
And he has small sized teeth. So that to me is not recession. To me, he has a little bit of recession on the premolars. That's it. Same thing with the other one. So yeah, CT graft is good. No tunneling. Yeah, I think he should be. And if he's a friend of yours, why not? But I would work on his home care first. Do some cleanings, oral hygiene. Just because if you operate like that, it's going to bleed quite a bit, and the tissue can tear. You're going with split thickness, so it'll tear a little bit, and that's not good.
Yeah. Okay. I think with this case, the few things that I'm concerned about. Okay, what's putting me off the most in terms of CT graph is actually the harvesting.
Okay.
And I find, how you taught the 1 incision technique, and then there's a 6 cut inside. I find it's very hard to cut. Okay, after the first cut, it's very hard to get a proper cut or a clean cut of the rest, to get like a nice square piece harvest to come out.
Are you changing your blades?
Yes.
Okay, you need multiple blades for that.
Yeah. But I find like it's the access, like you're trying to slice in between the layer.
Yeah, it's not easy. You can instead of creating incision number 3, you can use a periosteal elevator.
Yeah.
Okay, so that's not an incision. This is how you maximize the thickness of the graft.
Yeah.
And avoid the most difficult incision is actually number 2 and 3 are the difficult ones.
Yeah.
Okay.
I've seen some people I'm not sure, I think you probably know Lincoln Harris.
Yes, of course.
Yeah. When he harvests that, he took the whole squares out. He doesn't.
Yes, I know. I asked him about that.
Yeah.
I asked him about that actually yesterday. And I said, why are you doing that? Why don't you, if you want a CT, harvest a CT. Because then you're left with a big hole.
Yeah.
Because think about it. If you're harvesting a CT graft, the ideal thickness is probably around 2 millimeters.
Yeah.
Plus the epithelium gives you another millimeter. This patient's going to have a big hole in their palate for 3 weeks.
Yeah.
So I think it's worth the effort. Now, if you're harvesting from the tuberosity, okay, that's different. And he says his answer to me was, these grafts are more stable in my hands. I'm like, okay, thank you. I'm not saying it's wrong. But I would tell you, try both.
Yeah.
For this patient, do one side CT, one side free gingival graft, remove the epithelial layer, and then decide.
Yeah.
That's what I would do.
Yeah. But if you're saying that if you're doing you take off the epithelium as well, it's tend to be a little bit more uncomfortable, yeah? Like that when you're doing the free gingival graft.
Well, you go deeper, I would think. Maybe not. Maybe not. Maybe he's right. Maybe he's right. Maybe he's just harvesting a free gingival graft, 1.5 millimeters, and carefully thinning it. Maybe. He's very good. He does things that I have not seen before. He's done root coverage for implants. with a free gingiva graft and covered on top. So he's for real. He's for real. I like what he does, and he seems like a very nice guy, very passionate about dentistry.
Yeah.
And a general dentist, with good knowledge. So that's good. So, try both for this case.
Yeah. Okay.
Do you understand the flap design also?
Pardon?
The flap design?
The flap design for this one. Actually, you can go over that with me. That would be good.
Okay, so let's do that. So we have two options. Let's see. Let's do the color white. I think white is going to work the best. So, take the cursor off. Move the cursor away from the canine, the mouse. Okay, good. So I would start the following. From line angle to line angle. From line angle to line angle. Sorry. Okay. Line angle to line angle. Same here. So one tooth, okay, also on the molar. Here you have an option. You can keep it simple, straight across, straight across. Keep it simple. That's one option. The other option is you can make it like more triangular.
Okay. Questions. Are we looking at this as a conventional, or you're talking about tunneling?
No. We're not talking about tunneling. This is conventional split thickness flap.
Yep.
Split thickness flap. Okay? Conventional. CT.
Yeah.
Or CT. Okay? That's it. That should be enough. And then you release it all the way beyond the mucogingival junction, which is around here.
Yep.
And then you mobilize. This tissue moves here, here, and from here, it moves here. And then you suture it with sling sutures. That's the simplest way. I recommend every dentist starts here. Don't start with tunneling. Don't start with pinhole or vista or gumdrop.
Yeah.
Start with that. Okay, then you can always do the tunneling. Okay, so tunneling works different. Okay, it's tunneling from a coronal to apical direction, and this whole area gets tunneled. Gets done, including under the papilla. And then it needs to be tunneled here as well.
Area, is that the split thickness?
It's all full thickness with tunneling.
Yeah, okay.
Tunneling is full thickness, okay?
Yeah.
Okay?
Yeah.
That's what I would do. Meaning, you already did a tunnel for the previous. Remember the complication case? I think you did a tunnel.
Yeah.
Okay. Listen, you got to try different ways. Try different ways. That was an amazing case. Try different ways.
Yeah. So questions.
And all is a learning experience.
Yeah. So when you're doing the split thickness, okay, so you're actually doing coronal reposition flaps.
Correct.
So if the papilla here is quite long, so you need to remove part of this and then reposition it this way, yeah?
Well,
so just de-epithelialize the tip here, and then
you do this. Okay, so this part here gets de-epithelialized.
Yeah.
And then it can be pushed on top of it.
Yep. I have these questions because that's my feeling, but I'm not sure if it's necessarily the case. Is that when you're putting the CT graph underneath this, and then you reposition the flaps, but if the epithelium's around here doesn't come all the way up towards the where you want it to finish, would it in the end it's like will actually recede back? It's like, do you need the epithelium to cover the CT? Because in the end, the connective tissue, it's underneath layer, doesn't it? It doesn't have the epithelial cells.
No, this is how it works. You suture your CT separately, right?
Yeah.
Sometimes you can't cover the full amount of the CT, so you can leave it somewhat exposed. It's still vascular. It still gets vascularity, and it survives, and it will develop an epithelial layer. You will never have connective tissue exposed.
Yeah, but I thought
it will always have some migration on top of it.
Yeah, but I thought the process is that okay, you can't have CT. It won't be CT tissues exposed. But what will happen is that it just dissolved away, and then your graft goes back to wherever your epithelium's actually managed to cover.
Right. I mean, not all grafts are successful.
Yeah.
Right. That's why I encourage to cover as much as possible.
Yeah.
Even cover on top of the enamel.
Yeah.
And that's it. And then, it may recede back, but may recede right to the CEJ.
Yeah. Okay.
I would give it a try.
Yeah. And you're saying that you're raising the flap from extending from the mesial of the 3 to the mesial of the 6.
Yeah.
But you said like
distal of the 6. Distal of the 6.
Distal of the 6. Yeah.
Yeah.
Okay. But you only want a graph around here. Yeah.
That's the amount of tissue you can harvest. You can't harvest more than that.
Okay.
You'll get lucky to get this big piece. You'll be very thankful if you had a piece that goes from hopefully here okay, if you have this amount of piece, that would be great. So it'll be sutured to here. It'll be sutured to here. It'll be sutured here.
Yeah.
And then the flap covers on top of it.
Yeah. Do you need to suture it? You don't need to suture it apically, right?
No, not at all. You don't want to. And there's nothing to suture to anyhow.
Yeah, correct.
What are you going to suture to? To the periosteum? You want the forces in grafting to be in a coronal direction.
Yeah.
Everything coronal. Everything is top. You don't want to have any forces pushing it apical.
Yeah. Sounds good.
Sounds good. So how's the family?
It's good. I got married end of last year.
Oh, congratulations. Congratulations. Yeah. Any kids?
No, not yet.
Great. Thank you so much for all the support and the nice testimonial. I'm sorry that I constantly called you Dr. Super from Sydney. Did you see the campaign?
Yeah.
I think it was very successful, mostly thanks to, testimonials. The testimonials were really powerful.
Yeah.
And we're coming up now with a new course.
Yeah.
The Implant Gold Rush. So it's coming up.
Yeah. I don't know how this is going to go because because I'm still quite young and I have to try to focus my effort on doing certain aspects of dentistry first. And implant is one of the things that I'm still leaving behind. It's because I find that in my area, there's not a lot of demand for it. If I offer it, a lot of people would choose other options rather than implants. And I knew that I'm still learning orthodontics and I'm getting a lot more clients needing orthodontic works. That's why I focused my energy there first because I'm still learning there as well. I've only done it for about 2 years. So I think it's just a matter of me like going through different disciplines. So like right now I'm focusing on orthodontics and also the perio surgery as well. Because I find that with implants, like if I can't do this soft tissue management well and things like that, patient's going to come in with the upper centrals issues, and then it's going to be a disaster if I don't master these techniques first. And I see that.
Okay.
Yeah.
May I tell you my opinion?
Yep.
You can cross-train. You can cross-learn. It doesn't mean that you now have to focus only on implants or only on ortho.
Yeah.
But you need to look at dentistry not so much as in like in boxes.
Yeah.
A box, ortho box, perio box, implant box.
Yeah.
It's all one box.
Yeah.
Okay, let's stop the share for a second. Can you stop the share?
Yep.
Just on the bottom, it says stop share. There you go. So don't look at oh. No,
sorry, what happened there?
No, just stop you sharing again. Just stop the share one time. On the top, okay. It says stop share. Yeah. There you go. So don't look at all these different topics as I got to master this, then I master this, it's all together. It's all together. And if there's no demand for implants, create your demand, because your patients where you practice are missing teeth.
Yeah.
They're missing teeth, period. So you create something called the Blue Ocean. Have you read the book Blue Ocean Strategy?
Nope, but I've heard about it.
Read it.
Yeah.
That's what you need, because if you tell me that there's no demand for implants in your area, that tells me that there's a great opportunity, because the patients in your vicinity are missing teeth.
Yeah.
So that's I think is a very good focus. At least start by learning the theory.
Yeah.
And understand the just kind of the sequence of what it takes to replace a tooth with an implant. What's the big picture? Get familiar, and I think the videos that I'm going to share are going to be very helpful.
Yeah,
what's the sequence, start to finish, and then you'll see that it fits into an orthodontic treatment plan. You'll be actually learning ortho is such a huge advantage, because what's going to happen when you deal with the aesthetic zone and you have a tooth that needs to be extracted, you can utilize orthodontic methods and slowly extrude teeth, create more bone and tissue, create a better implant site, and you now have an unfair advantage over a competition. Not only do you know how to extract, replace with an implant, you also know how to utilize orthodontics to enhance your results. So you're actually in a very good spot. So don't postpone that, because somebody else will take this opportunity. In my opinion.
Okay, no, that sounds good.
Makes sense?
Yep.
Very good. What else? Any other questions? Last words. Words.
Not really, no.
Okay. Is your wife also a dentist?
No.
Okay.
Maybe that's a good thing. I don't know.
Who knows?
Yeah.
Who knows? Very good.
Yeah.
Well, what else can I tell you? Yeah, no, stay tuned. There's going to be a lot more coming up.
Yeah.
And are there any dentists in your community that may be interested in some of these courses and some of these trainings?
I think it's an individual thing, because I didn't think about it until I saw the course, and I remember on the first hours at your course, like it was very difficult. Like when you're talking about the terminologies, and said like, oh my god, this stuff that you heard about in uni, but you didn't get it you didn't get it then, and you didn't get it now until halfway through the first day, or by the end of the first day, it's starting to sink in. then say you get a lot more. But then I think I find a lot of dentists will probably feel similar to me. Like when they look at perio, is that okay? If they don't know a lot about it, they think they're not going to get into it. Then that's not the aspects that they're chasing after. You know what I mean? Because like a lot of people, like as a general dentist, like they'll be excited to go to like endo course, crown course, porcelain course, that kind of thing. But they said like, oh, if they have to deal with soft tissue, it's something quite unfamiliar with them. And I think the other thing that a lot of dentists don't like about it is like, like say, for example, grafting or crown lengthening, there's a chance that it won't work. And a lot of dentists don't like unpredictabilities.
But isn't it the same for restorative treatment? It may not work.
Probably, but maybe because they do a lot more of it and then they feel comfortable handling the issues, I guess.
Right. No, I agree. To each their own. To each their own. There's obviously some fear, there's some hesitation.
Yeah.
But you just take it one step at a time. Listen, look how long it took you. We're still training. It took you good 2 years.
Yeah.
And you're still learning.
Yeah.
That's why you're in a good position to get into implants, because you're already starting to understand flaps.
Yeah. I think the other issues I find is that like there's not a lot of patients taking up on a lot of these things, because where I practice is actually in a lower socioeconomic group. And, I'm seeing cases, I ask you about it, and, sometimes you book the patient and they decide like they don't want to do it anymore for like financial reason. Like they're seeing recession around there. So like, you know what? They say they can live with it. That kind of thing.
Nothing you can do about it.
Yeah.
Nothing you can do about it.
So that's why I find that like there's not a lot of case for me to do. It's like I'm seeing a lot. I tell them a lot about it, and not all of them go for it. And so that's why I'm seeing cases. Yeah, it's good. Some of them decide to do it, so I jumped on it.
You got to just work your way up, and you got to be prepared for the patient that want it and need it and can afford it.
Yeah.
You have to be prepared for them, because this is how it works. Not all of your patients have financial restrictions.
Yeah.
Some do, some don't.
Yeah.
So you focus on the ones. I'm sorry, you treat everybody the same, but you can focus on the ones that can afford it, and they have friends and family that can afford it as well. So all of a sudden you get into a niche of patients that can afford your treatments.
Yeah.
You focus on those.
Yeah.
And you market to those, and you do more and more for them.
Yeah.
I'm not saying don't treat people that don't have money, but you got to be, you spend time and money to educate yourself. The doctors on our platform, we have 180 people. They spend $1,000 to take the course. It's actually compared to the benefits and what their return.
Yeah.
It's quite affordable.
Yeah.
I have a lot of people from Australia, actually.
Yeah.
A lot of Aussies.
Yeah, I think it's good because the thing is there's not a lot of people teaching it here or teaching it well. So I think the three main courses that people heard about, it's probably yours, Pat Allen's, but he doesn't come here all the time. And then Harris, Lincoln Harris. But he's only like a handful a year as well. So he's probably seeing maybe 10, 15 dentists a year for this type of courses. So there's not a lot of demand, but if people are looking for it, usually there's these three that they saw. I'm not sure if you still come to Australia.
I don't, not so much, but I do the online training.
Yeah.
But, if there's an opportunity in the future, if we can gather, 30, 40 dentists, I think we can organize something.
Yeah. But yeah, so I guess I called you at the right time.
Yes.
So that's good.
That's good. Yeah, you caught me at the right time, exactly.
Yeah.
Before I stopped all my traveling. But very good. Listen, Dr. Super, good luck with everything. It was great talking to you.
Yeah.
If you need anything, you know how to find me.
Yeah.
Oh, one more thing.
Yes.
We're going to launch the new course So that's going to be the implant gold rush. It's going to be actually broadcast live.
Yeah.
And filmed live, and there'll be an announcement. There'll be an online component, an audio component.
Yeah.
Mentoring, live webinars coming up soon.
Yeah.
But we'll also have a live course in LA. So if you want to ever come here with your wife, make it a tax-deductible trip to the United States.
Yeah.
And that could be combined with a course sometime in September, number one.
Yeah.
And before that, we are looking to find the new surgical master.
Yeah.
Okay, like an apprentice show.
Yeah.
Maybe you can be a good candidate for that.
Cool.
Okay.
Yep.
So I'll be like Schwarzenegger or Donald Trump, and I'll say you're fired. You're fired. We'll get like 12 guys from all over the world, and we'll do like it's like a competition, but more for fun. Not people with a lot of experience. For example, somebody like you can be a great candidate because you are, learning, practicing, making mistakes, keep improving.
Yeah.
And then every week we eliminate somebody else.
Yeah.
Every week we'll eliminate somebody else, and then the winner is going to be the next surgical master, meaning he will come to, we'll pay his trip, we'll give him the free course, hands-on.
Yeah.
And I think it's going to be fun. I think, it's obviously a promotional thing. Yeah, so we'll call for candidates, but we'll do stuff like that. And, it's all going to be online.
Yeah.
Okay, so then at some point, we start from 12, 11, 10, we reach 2, and then, you're the next surgical master.
Yeah, that sounds good.
It's going to be fun, I hope. I hope we get some good candidates.
Yeah, cool.
Okay, my friend, listen, all the best. I got to go to work.
Yeah,
Keep up the good work.
Yeah,
okay,
thank you.
Take care. Bye.
Yes.